Good morning. My name is Nitin Mishra, and I would like to thank American College of Surgeons, Dr. Dozoa and Dr. Tyler for the kind invitation for this talk. My talk is titled, Can I Reverse the Diverting Ileostomy Early Indications and Considerations? I have no disclosures. So initially, I would like to start off with the indications for diverting ileostomy. As most of you are aware, we make diverting loop ileostomies for any high-risk anastomoses. These are low colorectal anastomoses, less than 7 centimeters from the verge, coloanal anastomoses, of course, the pouches, the ileoanal pouches, and post-radiation pelvis, immunosuppressed patients, and malnourished patients. The usual time frame for reversal is 12 weeks or more. We tell patients 2 to 3 months, but more often the reversal ends up getting done at 12 weeks or later. Most patients with rectal cancer will end up getting reversals after they finish their chemotherapy, which ends up being anywhere between 3 to 6 months after initiation of chemotherapy, which ends up being 4 to 7 months after their surgery. So the usual time frame at this time, the standard of care is 12 weeks or more after the loop ileostomy creation. So early, for the purpose of this talk and for the purpose of the data analysis, the review of literature out there would be within 2 weeks of creation of the ileostomy. In other words, you'll see many studies which compare reversal of ileostomy at 1 month or at 2 months compared to 6 months. That is not what we are talking about here. We are talking about taking down the ileostomy between days 10 and day 14 after creating it. So really early in the life history of the ileostomy. So the question is, what's the rationale for early reversal? A lot of surgeons who know that I've been leading a trial in safety for early reversal, they even asked me, what's the point of making an ileostomy if you're going to take it down between days 10 and 14? I think it's important to, first of all, address that this is a very genuine question, very good question. But secondly, also to look at data from animal models and also to look at a subset of patients who may not have very high-risk features for a leak who may benefit from early reversal. So when we look at healing of anastomosis in animal models, we see that collagen deposition occurs such that between days 7 and 10, the synthesis of collagen overtakes that of dissolution, which makes the anastomosis quite stable by day 10. And thus, if the anastomosis is protected up to day 10, theoretically, we should avoid the chances of a leak. Timing of leak, most anastomotic leaks happen in the first 2 weeks. There are leaks which will happen after that. There are leaks which even happen after a month. But if you analyze those leaks, you will see that there are high-risk features usually associated with the late leaks. There is a randomized control trial, which I'll talk about in a little bit as well, comparing early versus late reversal. So when you look at these factors, they give us a basis to try early reversals of ileostomy. This is the paper which looked at healing of experimental colonic anastomosis in an animal model. It's from Sweden, and they showed that synthesis of collagen surpasses collagen dissolution on day 7 at the anastomotic site. So by day 10 to day 12, the anastomosis should be very secure. The EASY trial, which is the early closure of a temporary ileostomy in patients with rectal cancer, it's a multi-center randomized control trial published in 2017 from Europe. And this table is, I would just share one table with all of you, which shows the 2 groups, early closure, 55 patients, and late closure, 57 patients. As you can see, none of the patients had an anastomotic leak after reversal of the stoma. The morbidity rate was much less in the early closure. Of course, it is spuriously high in the late closure group, because if you see here, the chances of skin irritation, stoma ulcer, parastomal issues, parastomal hernia, etc., is obviously going to be high if you leave the stoma in there for a long period. So I do acknowledge that the late closure group has a spuriously elevated amount of complications. But when you think about it, these are complications which can be avoided if we can safely take down loop ileostomies early. So this is an important slide. If you're interested in early reversals, I would urge you to read this paper. So what are the benefits? The benefits are time. The patient saves a lot of time in terms of time without an ostomy. So if you take it down within 2 weeks instead of 3 months, a young patient who was working could go back to work. A patient who's retired and was golfing could go back to golfing. And of course, they save a lot of costs in terms of appliance, nursing costs, and complications which are associated with ostomies being in place for a long time. One thing to note is a lot of rectal cancer patients are getting total neoadjuvant treatment now. So if they get total neoadjuvant treatment and you reverse their ostomy within 2 weeks after their surgery, then they're done with the rectal cancer treatment, which is quite an appealing option for many patients. Biggest disadvantage is that you can have late anastomotic leak, which then really makes it really is important for all of us to ask the question, if that happens, then does one such case justify taking down many patients early? So that is why I think it is very important to pause and emphasize that we do not have enough data to make this standard of care by any means. So it is a big thing which needs to be clarified going forward with multi-center randomized trials and long-term data to make sure that this is a safe thing to do. So this is very important that we select at this time when the community, the surgical community, is trying to figure out whether this is something which can become standard of care at some point. It is critical not to include patients at high risk. And it is also important that the patient understands that this is at this point not standard of care. Technical considerations: the operation is exactly like quote-unquote late takedown. It is an easier operation to do because there is less scarring, no hernia sac, and it's a shorter operation. We have done 5 patients under protocol so far, and none of them have had leaks. One patient had had prior radiation, and so far we have not seen any major complications. Of course, this is an ongoing trial, and 5 is a small number, so maybe we'll see more complications in the future. We'll report our results once the trial matures. So in summary, early reversal of a loop ileostomy is feasible. Its exact role in practice has to be defined. We need larger trial data. We need to be very cautious not to do this unless it is under a study protocol. It is not standard of care currently. The indications, of course, are high ostomy output in the early phase, or stoma troubles with pouching or skin reactions. So those are indications when you can consider it even without the patient being under study protocol. But if you're reversing an early ileostomy without any other reason, then it must be under study protocol, and the patient must know that this is not standard of care, and that the risk that they are taking is if they have a delayed leak, then the making of ileostomy was essentially for no good reason if you reverse it and the patient has a leak. So that is a very big red flag, something to be considered. And so I should emphasize, if you're going to embark on this journey, please have an IRB protocol under which you do it. Thank you for your attention. I'll be happy to take any questions during the panel session. And thank you again to American College of Surgeons, Dr. Dozua and Dr. Tyler for this opportunity.